review and scrutiny meeting. This meeting is being recorded but not live streamed. However, the subsequent broadcast via the Council's meeting YouTube site will be available after the meeting. Members of the press and public may record and take photographs, except where there are confidential or exempt items. Can I remind officers and guests joining us on Teams to please keep your cameras and microphones off unless speaking, and please use the raise hand button if you want to speak. For officers and guests in the room, please speak directly into the microphones to ensure that the live streaming is clearly audible. As apologies, can I ask both the members and the scrutiny officers if they've any apologies for the meeting? I know we have an apology from Council Ford. Do we have any others? No, I think then we've got a full house. Right, so declaration of interests. Can I ask members if there are any declarations of interest to make at this time? Item 4 is action notes and matters arising from the meeting held on the 14th of March. Are there any points anybody wishes to raise regarding that meeting and the minutes? I assume not. Okay, can we agree them as being correct? Yes. Yes. Thank you for that. The 5th item is the action tracker, and Fiona is going to update us on that.
Thank you, Chair. There are 11 actions still to be completed on the action tracker. They're shown in the right-hand column that there isn't an update next to them. So Addy and I will work to follow those up and try and ensure that those are completed by the end of the municipal year. The other thing I just want to bring to your attention, it's covered in one of the points in the action tracker, but the briefing has been arranged for the Day Opportunities Cabinet report for next week on Thursday on the 20th of April. So that was something that members had asked for at the last meeting. Thank you. Okay, thank you for that. Item 6 is a report from the Integrated Care Services, and David Melbourne has come to present his report on the Integrated Care Services. At the last meeting, members had said they would like a bit of an update and understanding of the Birmingham Place Committee, and David is going to mention that briefly as part of his presentation. And we were looking possibly in the next recommending to the committee for next municipal year that item is discussed in more detail. We've got 40 minutes for this item, so David, if you could talk for about 10 to 15 minutes to have the councillors' questions for about 25 minutes.
Thanks, Chair, and thank you for inviting me today to talk through our first integrated care partnership strategy that we are required to produce by the Health Act. And just to remind colleagues that this is a partnership strategy. It isn't an NHS strategy, and the Directors of Public Health have been very much involved in driving this. Indeed, I asked Dr. Justin Varney, to do the majority of the work behind this, and he has. He's been heavily involved in this. His fingerprints are all over it. The Integrated Care Partnership is a jointly chaired committee of the NHS locally, and it's jointly chaired by Marion Khan, the Health and Wellbeing Chair for Birmingham, Karen Grinsell, the Health and Wellbeing Chair for Solihull, and Professor Patrick Vernon, the interim chair of my organisation, the NHS Birmingham and Solihull. And once this has been produced, one of the things that I have to do is produce a response to it on behalf of the NHS locally. So one of the things that you might, Chair, want to consider later, I know you are talking about the work programme for this committee, is how you hold me to account for that, and indeed what the relationship is between the place boards and this committee, and I can come on to that later. Now, this has been driven by a significant engagement approach, and I'd just like to say thank you to a number of people who've been involved in that, but particularly Birmingham Voluntary Services Partnership, who've done a lot of work for us in terms of engagement on this, but we've also engaged with local staff and local citizens as well. And just to say, the Integrated Care Partnership does have citizen representatives on it as well. So there has been a significant amount of engagement behind this. Now, when we thought about developing this, what I didn't want was a large document that would just sit on a shelf somewhere and just gather dust. And if you look on page 15, it actually highlights already across Birmingham and Solihull, we have a number of strategies, the health and wellbeing strategies, and we also have an inequalities strategy. So how do we bring all that plethora of different ambitions together? And I think where Justin and my Chief Policy Officer, who helped develop this, struck on is it's almost what they call a Carol Vorderman option. So they've got one big priority from the top and 5 priorities from the bottom. So what's that one big priority that we are looking at? Well, that is the overarching priority is to improve the life expectancy for people in Birmingham and Solihull. And there are 3 simple aspects to that. The first one is to increase life expectancy at birth and at 65 years of age. So in 10 years' time, we're on par with the West Midlands. We're some way behind that at the moment. But that's not enough. Many people who have longer lives also have disabilities, and we want to make sure we've got, again, increase a healthy, disability-free life expectancy over that same period to be on par with the West Midlands. And then finally, we want to reduce the gaps in life expectancy between the least and most deprived groups and between ethnic groups as well. So they're the 3 areas that make up that very simple statement that we want to improve life expectancy for people across Birmingham and Solihull. So live life longer, live a longer life disability free, and reduce those inequalities. Now, to do that, the analysis that's been undertaken behind this report boils it down to tackling 5 key drivers. And that simplicity, I think, is important because everything then we do will link back to those 5 key drivers. And I would suggest, Chair, that that's as important as some of the things I've been talking to the committee about around UHB, around ambulance turnaround times, around primary care access previously. They all link into that. So what are those 5 key drivers? And if you live in the city or have worked in the city, then you'll be well aware of these. And as elected members, I'm sure you know what these are. So the first one is circulatory disease. Now, 1/4 of the life expectancy gap for males in Birmingham is due to circulatory disease, and 20% of that in women. So we need to tackle that. The second one is infant mortality. It's 6.6 per 100,000 in Birmingham. And one of the case studies that Justin has included in there about Laidwood and Perry-Barr and the health hacks available to pregnant women show how we can start to address infant mortality. I know from most of my career has been in a provider organisation. I know from working in a provider that if I think it's 1/3 of the women who look to deliver at Heartlands Hospital a baby already smoke, which outcomes mean for children and for the woman that's not good. Linked to that is respiratory disease and reducing respiratory disease. So asthma in children all the way through to sort of lung disease later in life. And there's a case study on page 24, and I'm really proud that we've got people who real specialist clinicians. There's a picture on page 24 there around that respiratory disease that shows one of the specialist clinicians at BCH just down the road, Dr. Satish Rao, talking to school children about asthma and managing asthma and actually getting more self-care in asthma. The 4th area is cancer. Now we're going to have 3 diagnostic hubs in Birmingham, but I think it has to go beyond just the diagnostic and tackling obesity. We highlight in this document the importance of that and the prevention piece. And finally, mental health. You all will know from your constituency the prevalence of mental health across the city at the moment. And that's not only in the preventative space. we already send too many patients outside Birmingham because we don't have enough beds in Birmingham. And I can tell you from dealing with some of those cases that not only impacts on the patient, but on the family and their mental health as well. So as I said, there's a significant engagement behind this, and the voluntary sector has been very much involved in it, staff, communities of interest. So we have done a lot of work behind that. As I said right at the start, Chair, I think I would ask that you hold my feet to the flames on this. And one of the things that we've set out at page 28 are the metrics by which we should be measured to say, are we making progress? And we should be able to do that as a minimum on an annual basis, but probably on a 6-monthly basis as well, to show you and demonstrate that we are making progress, that we are doing things, because this is the thing that will make a significant difference for our population. And that might be something you want to consider later as you talk about the OSC plan for next year. As I said, I have to produce a 5-year forward view report for NHS England as a response to this, which again you may well want to see here, and I suggest that you would want to see that here and test that here. And you might then say, well, where does the place committees fit into this? Well, the place committees are part of our delivery architecture, effectively. They are subcommittees of the board of the integrated care system. So the ICB is responsible for about £4 billion worth of health and care resources that come to Birmingham and Solihull. We commission everything from ophthalmology and dentistry from the 1st of April, all the way through to the very specialist services down the road at UHB. And we are responsible for planning care, making sure that care is delivered, and making sure the system's working together. A key subcommittee of that board and that organisation are the 2 place boards, one in Solihull, one in Birmingham. Now, unlike other ICBs, when we set our inception framework out, I wanted this to be a true partnership with local government, and asked the 2 chief executives to chair those. Talking to Deborah, she felt that Professor Betts would be best placed to do that. I agreed, and so Professor Betts chairs that meeting on a regular basis. It's still getting up and running, but what are the type of things that it should be looking at? Well, first of all, last year I set 25 million pounds aside with something called the Fairer Futures Fund. Now, this is health money, and it isn't for waiting lists, it isn't for dentistry, it is for the things that contribute to health from the wider population. So it is about how we support the third sector. It's about how we make sure that that we commission services from the voluntary sector and address that. That money sits with the place board. I've delegated that down to the place board, so it's a local government thing. They're responsible for developing the integrated neighbourhood teams, which is a key element of our strategy across Birmingham and Solihull. We passionately believe of investment in front-end services. So primary care and community integrated teams set out in the Fuller review recently. Claire Fuller is a chief exec from Surrey who was commissioned to do some work on about the future shape of the NHS, and increasingly looking at joint commissioning. So I will start to pass the money down to commission those integrated neighbourhood teams in Birmingham, and make sure that they can actually do that in the way that makes most sense for Birmingham. I'm not sure that somebody sitting in the Wesleyan is best place to do that. I think somebody sitting more locally, closer to Citizen, would be the best place to do that. So that's what the place committee is doing. It is still developing, so we're ambitious for this, and I'd just like to thank Graham for everything that he's doing on that. We've got a meeting again on Friday this week where we look at some of these aspects, and we had our ICB board meeting yesterday, which Graham does attend, so that so Birmingham City Council are part of that. So that's my overview, Chair. I'm happy to take any questions.
Okay, thank you very much for that, David. Members' questions. Councillor Pitcher.
Thank you, Chair, and thank you, David, for the presentation. I've got a couple of quick questions on the structure of the ICB, ICB, and then there's a few questions on the strategy. So you mentioned there about the place being chaired by Professor Graham Betts. I was interested to know why it's an officer that's being given that chairmanship rather than an elected representative. So that would be my first question. You've not really talked about the localities and kind of any further down than the place at this point. And it's just, again, I think we've asked previously at this committee around how anything further down would work. And you talked there about quite a lot of devolution of funding that goes to the place board. And that's partly why I'm asking, well, should that not be elected representative chairing it if there's going to be so much devolution of resource to it? But is what's going to be devolved down to other levels below that? On the strategy itself, I'd be interested why the target for is only the West Midlands average as opposed to the England average. So that's on page 5. Some of that, and because the England average is lower, so that's a kind of would be a better target to aim for. So why are we only going for the regional? The reduction of health inequalities doesn't seem to have any actual target; just as reduce them. And obviously, any reduction in health inequalities would be great, but I'm just again wondering why there's no kind of actual hard kind of thing to aim for there. And yeah, the talk about the long-term prevention approach, which obviously I completely agree with, but obviously all the problem with prevention is in the short term you still need to do the firefighting as well. So how does the resource to keep on doing the firefighting and start the prevention without kind of impacting on both kind of happen?
Some really good questions there. So I'll deal with the issue around the officer chairing the place board first, and that is because in the NHS structure, that officer will be responsible to me for delivering that, and it probably is not appropriate for an elected representative to be doing that. Elected representatives do go onto the ICP, the Integrated Care Partnership, and are in the Integrated Care Partnership. We did have this debate at the inception of the ICB, and if you looked wider afield, other systems do have councillors chairing those meetings, but they're very different vehicles placed in those areas than what we're setting up here. Now, one of the things I would say is that 12 months we have to do a review of our governance. And it might be that could be something, Councillor Pritchard, that I feed into that. But certainly there was consensus at that time, recognising that Paulette was the chair of the Health and Wellbeing Board at the time when we set this up. Paulette Hamilton, Councillor Hamilton, that we look at that again. But what we do in Birmingham, we'd have to do for Solihull. That's so. Because that covers both aspects, so we'd have to do it on both aspects. In terms of the localities and neighbourhoods, I think it's a really good challenge, and that's what the job of the place board should be. It should be driving down, looking at those locality and neighbourhoods and making sure that we are delivering the services at the appropriate level. If you talk about primary care isn't delivered at Birmingham level, it's at a neighbourhood level. And the integrated neighbourhood teams, by their nature, will be at neighbourhood level, so they have to get into that space. I still think there's more work to do there, and I know it's something that Graham is working on, but he's working on it around a template that Birmingham City Council have already set out in terms of neighbourhoods and localities. So we're not creating something new; we're building it on the template that Birmingham City Council are already doing. Why aren't we more ambitious? I think that's a good challenge. In the report, we say it's realistic report. Now, we could be more ambitious. I mean, getting to West Midlands average, given where we are currently, is going to be a challenge. And we want it to be realistic. And there's always a balance, isn't there? Setting something that you feel you can achieve against something that is just not achievable at the moment. There's 42 ICBs in the country. We're 42nd out of those 42 in terms of health inequalities, with Surrey Heartlands at the top, the least deprived and the least impacted by some of these measures. So getting us up that board, I think, is ambition in itself. One of the things that we have said since we published this and talking this through with Justin is the suggestion that we do a full review after a year and bring it back. And at that point, we might want to say, well, if we've made good progress, we should be pushing ourselves more. You said about prevention. Look, I mean, the Patricia Hewitt has just published a review into the NHS structure. And one of the things that she said is that 1% of our allocation should be allocated to prevention. It sounds a small amount, but when a system's got £3 billion deficit, which the NHS currently has, that's going to be very difficult. Now, that's one of the reasons that I wanted to get that money across to local government for the Fairer Futures Fund, because that, to me, can make a difference. And if I can give an example, so when I thought that through and we thought this through, I used to work at the Women's and Children's Hospital, and they've got a fantastic charity there. And one of the things that we did there was the charity funded some peer support workers, youngsters who are out of work, who've got mental health issues in the city. And we put £300,000 in. On the basis of that, we got Gymshark to put in another £1 million so that they could continue with that type of approach, that preventative approach for the next 3 years. For me, I'd like to see that Fairer Futures Fund actually used in that way, almost in a social entrepreneurial way, to generate more investments, to go and get more investments from the private sector or from other trusts, big trusts, to do that and actually focus on prevention. One of the early, so I think it's a real positive that we've done that. We've got 25 million, we spent 400,000. So that's not great, is it? And I think, again, that might be something, Chair, that you want to come back and say, where are we? Because I've delegated that money down to the place boards. There was one more, which
why there's no actual kind of hard target on reducing health inequalities, and why it just says reduce it. It doesn't give like by X amount or Y amount.
I'm not absolutely sure why Justin didn't put a specific target in. I would guess he did try in page 28 onwards to get as many targets as possible in there and balance them. But I can check back and make sure that Fiona gets something back to you to tell you why that is. There would have been a good reason for it. Otherwise, it would have been in there, I suspect, because this took months and months to develop, and Justin and Ruth, the Director of Public Health over in Solihull, put a lot of thought into it.
Yeah, I mean, if we could have that, I'd be interested to see it, because I think, obviously, reducing health inequality, I think we'd all agree with that.
Yeah.
But I mean, by how much? I mean, obviously, any reduction is good, but again, like you said earlier, in terms of a target can help stretch and kind of give something to aim for. So I think, it'd be good to understand the reasons why, and if it would be something that would be added in later.
We do have a health inequality strategy for the system, and from memory, there are some targets in there. And Justin was very much involved in that. So it might be that he's just not included those, but I will go back and check on that.
Thank you. Councillor Tilsley.
Thank you, David, for your presentation. The one issue that there's a couple of issues that I wanted to take up. First of all, you've made the comment about neighbourhoods. Having been involved in health for a long time, there was a branch of the health community that wanted the NHS to change its name from National Health Service to Neighbourhood Health Service, so that we are really getting involved at a local level and giving it the importance that it needs locally. So it's just a little bit on one or two people's plate. You mentioned the shortage of mental health beds.
Yep.
As you'll know, we're doing a review of children and young people's mental health. And one of the constant themes that's come across is the lack of mental health beds for children and young people. If you put that together with the adult shortages, I think it's a real problem because, as you rightly identified, it's not just the individual that it causes harm to if there's no beds or a bed is a long way away. It's the family and the support mechanism that is within the family to help the individual. So as the Commissioner, I hope that you'll take that on board and try and ensure that we are providing the right number of beds. And I appreciate that's working with Birmingham and Solihull Mental Health Trust, but it's also working with the Children's and the Women's Trust. But I think it needs to be a priority. And the last point, and Councillor Pritchard made this comment, and it is prevention better than cure. Now, in my time, I was on the South Birmingham Police Lieutenant with David Cox. One of the things that we did desperately try to do was to get upstream as far as prevention was concerned. Obviously, from the statistics, fail, but it doesn't stop us from trying. And one of the problems that we've always got is different communities' lifestyles and eating habits. And I think that we need to focus on that more because COPD is a problem that comes from lifestyle. We are what we eat, basically. And therefore, anything that you can do, and it was, you mentioned, Patricia, it was 1%. That would be a very, very large figure when you take the NHS budget. It would be considerable. That if that money could be put into prevention, it would reap untold benefits as far as the acutes are concerned. I know. So it's just a few random thoughts from your report. But I'd be grateful if you could take on board.
Thanks, Councillor Tilsley. They're all absolutely spot on. In terms of neighbourhoods, like I said, integrated neighbourhood teams are where we are trying to build the NHS and the wider health and care system from. In terms of mental health beds, I'm passionate about this. We are incredibly underbedded in Birmingham, not only for mental health beds, but for we haven't got one specialist learning disability bed. So we've just dealt with over Easter a Birmingham citizen who is located in Greater Manchester. The CQC had closed down their private home in Manchester, and it took my team. It took 6 weeks for our team to find them a place at just down the road at the Mental Health Trust. But that's only a temporary place until we build him a bungalow, the citizen a bungalow in Birmingham. We just don't have enough beds, and our biggest priority for our investment in capital is mental health beds, NHS provided mental health beds, probably in the north of the city on the BSMHT side, on the Birmingham Solihull mental health side. After that, it's the front door at Heartlands, the Heartlands. Yeah, and we will keep looking at the prevention. You know, I'm a chartered accountant by background, so I won't commit to the 1% at the moment. So. Yeah.
Okay. As we go through, that's all your 5 clinical areas. I think that's the right list. I was pleased to see infant mortality in there. This committee took a review a couple of years ago about this, in which there are some very specific targets. Actually, I think it's reduced by 50%. The prevalence in. So I think when we get to the detail, there will be some targets in there. So I think the clinical areas are on it. What I would be wanting to see is those clinical areas looked at life course, mental health, for example, a particular issue for young people, let's say 10 to 18, and those people are very vulnerable at that point. I think it is. And I think that the strategy needs to be explicit in that there are different issues as you move through your life course in respect of mental health. I think that's strategic. But appreciation of the effect of course on those conditions, respiratory disease in young people, again, I think will be another issue. Older people, different issues. So I think it's like to see that expanded out so as to be more clear about what those clinical priorities are as they appear to people at different stages of life. The third that I'd like to see a bit more on is the approach towards inequalities. I like the Marmot model, Marmot's principle, in how we tackle the issue of health inequality. In the report, it would have been good, I think, to have seen a recognition of the strength of the Marmot approach, which of course takes us into the preventative world, in a very broad. Money, NHS money was dedicated to zones or areas, and it could be used in a whole range of ways by partnerships. For example, crime prevention, which would be causing social isolation, stress, legalising in alleyways was a justifiable use of funding from the NHS in areas where social stresses were causing ill health. So when you're there at features, right, which I think is a great initiative, I'd be keen for the committee to know more about the specific terms of reference for this delegated funding to the place level. What can it and can it not be used for? So what are the limits? So it's being extended into that preventative approach. Obviously, I think it would be good to see as much flexibility in that as possible. I suspect hands may be tied at some point in how flexible that is. So can we have some more information on that? I think that was suggested we want to pick that up further in this committee. The final point, and Councillor Richard also mentioned this, going local is great, but we have no infrastructure whatsoever on how to organise at a local level, community engagement, councillor engagement, patient public engagement at the level of the integrated neighbourhood partnership is an unknown components of this new model. I think it'd be obviously when we get the report in place, that's probably the better place to pick them up. But I think if we can take some feedback that we are alert to the absence of that infrastructure at the moment and enthusiastic about steps to build that in. The Southern Councillor, I know the Town Council have been looking at a way of trying to make that happen, using their local mechanisms to engage people at the ward neighbourhood level. I think that's a model one we're looking at for other parts of the city that don't have that governance infrastructure, but make something equivalent to that might be what's needed. So I think there are a lot of mechanisms to that neighbourhood level. But the ambition, I'm sure, of this committee will be to see how far we can push that and to be supportive, if we can, in helping build those infrastructure. So I think that message might be useful feedback.
No, that's really useful. Thanks. Thank you, Councillor Pocock. And just to assure you that the way in which we've set up the Fairer Futures Fund means that our hands generally aren't tied. Now, the one thing where I will, as the accountable officer for the NHS locally, what it can't do is duplicate. It is basically mean that the local government was going to spend something, save some money and uses this instead. However, we know I'm talking to Tom McNeil, the Health and Crime Commissioner locally, about how we might use the future fairs with some of the initiatives that he's developing. And again, if you're talking to the place partnership, from my perspective, making sure that you're assured and you've got oversight of where that money is being used and how it's being put out, I think is a useful, it is a really great function for this committee.
Thank you for your presentation. I just had, and forgive me if this has been picked up in the past, I've been recovering from significant health issues, but I just immediately felt uncomfortable with the use of disability free. It doesn't feel, can I ask, it's a protected characteristic, obviously, and I just wanted to ask why that term has been used. Can you define the term? And has there been any feedback on perhaps not using that term? Because equalities are used throughout, signposted to throughout the report. And on that similar vein, just on the equalities, I hear from constituents very frequently and friends and my own experiences on the women's equality section with the metrics for the goals, I think it's page 25 or 28. There's no reference to PCOS, endometriosis, PMS, and women's health issues. And I know that many women have to go through a 10, 15, 20-year battle to get validated for the healthcare that they need. So I'm disappointed to not see that being considered within the plan. On the localization aspect, I really do agree with colleagues for the points that they've made. And I actually think this links into preventative care. Very often patients do go to their GP to raise what would be an opportunity for preventative intervention, and it falls on deaf ears. So I have a question or skepticism perhaps about how localization of healthcare is and using that to advance prevention is going to feel for the patient or a service user, because there's often quite a significant resistance, particularly when there is problems with recruitment and retention in services in the local area. I know that several services in South Birmingham are really struggling with that at the moment. Just finally, on the fairer future population, maybe just saying this wider to the committee, but I would really like to see diet included and nutrition. I think the report is perhaps a bit, could go into greater depth on nutrition. Yeah, those would be my comments and questions.
Thank you, Councillor. On the disability-free issue, I mean, this has gone through a lot of engagement with the voluntary sector, with disability groups, but I'll go back and check on the drafting of that there was no feedback on that. I'm not aware of any in terms of that phrase, but clearly, if there was an issue around that, we will rephrase that and relook at doing that.
I looked at disability
yeah.
resolved, and immediately I was like, that, well, am I? It doesn't advance a positive perception of disability as a protected characteristic.
I think what Justin was thinking there is where somebody is living with a chronic condition, you know, probably later in life particularly, but it could be young in life, and how do you make sure that that's more manageable? And that is described in here, but there may be a way in which we can phrase that and frame that differently, so I'll take that on the chin. In terms of the 5 areas, I hear what you say about women's health, and remember that I used to run the women's hospital. However, what we needed to do was make sure that we didn't try to boil the ocean, that we got the 5 areas that our clinicians are advising us make the biggest impact for our population. Because we could put a whole range of things here, if I'm absolutely honest, and they're the 5 things that the professionals are saying make a difference. Now, again, we'll take that back. We'll listen to that. And as I said, I think, as Justin has said, he wants to look at this again at the end of the year, and it'll be an ongoing dialogue with this committee to do that. In terms of the localisation of health and what this means for a resident, if I could just give you an example of Ash. Ash is a resident in East Birmingham. He went to the Iridium practice to see Dr. Sabina Silliman. He wanted to be referred to the Birmingham Solihull Mental Health Trust for advice, and to the ROH because he got shoulder pain. The Iridium practice is fantastic. If you've not been out there, go out there, because that is what we are aiming to get to. They've got a fantastic service there where what Sabina did is referred him to to basically a group who could look at those areas. He became a peer support worker. He led a walking group, and he didn't have those referrals. He got back into work, and that's what we're trying to aim at from the citizens' perspective at a local level. But coming back to what Councillor Pocock said, there isn't always the infrastructure at a local level to do that. Iridium have invested their money to do that in primary care, and they've got a brilliant social prescribing service that helps them support that. And the GP herself didn't spend 5 minutes or 10 minutes; she spent 15 to 20 minutes with Ash to do that. So we will have to get there over time. It takes time to do that, but that's the vision. If you ask me what we want to get to localisation is where we want to be.
Thank you for that. Sorry, Chair, can I just come back, because I wanted just to correct. Sorry, when I was referencing women's health, I was actually referencing the measuring success, page 29. There's the goals or objectives include uptake of long-acting reversible contraception and such. And there's other inequalities. I think a lot of women in Birmingham would say that their experiences with women's health and it's fantastic of your experience in the women's hospital, but not every woman in Birmingham gets to the women's hospital.
Absolutely.
So I'm, as I say, from just the speaking to constituents and in my own life, I know that this is a very common issue, and I think there could have been room. And I understand what you say about boiling the ocean, but I feel like there is a case for that now. Because if our overall objective is disability free or in chronic illness free, which I think is actually what we're alluding to, I would consider PCOS and endometriosis, which has huge implications for the labour market, to be valid, worthy of being on that metric.
Thank you. Thank you. I've got points to raise myself.
Yes.
You gave an example of a programme being running in Solihull in terms of preventative work. The pilot project, which Gateway and another number of other organisations such as Solihull together are actually linked involved. But is that being moved forward on from a pilot project to a more mainstream project? And that would that, if so, would that be in Solihull and Birmingham? And would that be something we run integrated neighbourhood teams? And also the follow-on point to that is, I noticed that a number of those people who went through the programme were referred back to the GP. I just wondered if we got any feedback in terms of whether the GP felt there'd been positive progress in terms of physical and mental health issues for those particular patients.
Yeah, Chair, apologies, I don't know the answer to those questions. I can get, so I've read the strategy, I've read the case studies, but I don't know the detail behind every one, but I can get you a response to those.
You could do that, would be great. But it's a general principle. Is that pilot project going to be mainstreamed out? Because I think it really is really useful, because I'm aware of the Iridium practice myself, and I know some of the work they've done there has been really positive in terms of helping people to get more control in terms of their own lives and be more. So yes, it's going to be moved mainstream.
So on that specific project, I don't know. I'm not sure. However, I mean, there is a theme here, as Councillor Tilsley said, about how we put more resource into mainstreaming preventative work. And what I've just talked about at Iridium, what you're talking about, much of this is preventative work and not the things that we look at UHB to in terms of ambulance turnaround times. And I do need to look at the allocation of money that we've got and see how we can free some up to make sure that it just doesn't go on the waiting list and on the other areas. I'll be honest, that's difficult at the moment because there's a real political imperative, rightly so, to reduce those waiting lists, to reduce the number of people waiting over 102 weeks and over 78 weeks. But I think, we will continue to have waiting list issues unless we start to address some of these long-term determinants. We've got long waiting lists in mental health, as you'll be aware, which often don't get talked about. So look, I can't give you an answer that they'll all be mainstreamed, but it might be something again that the committee want to bring me back, and I can actually prepare something on that to talk to you about.
That would be fine. Yeah. Then the second point was regarding the section you've got on the inclusion health, which is for communities where they may be homeless, vulnerable for a whole variety of reasons. And you obviously flagged up the fact there will be limited indicators in terms of what their health conditions are going to be. And I noticed that's been included in the 5-year strategy. So I just wonder if you got something in line in terms of interacting with those particular communities so we can get some clarification as to what their health indicators are. So by the time that you've reached the 5-year target point, we're clearer in terms of what those communities' issues actually are.
It's a really good point, and I don't think we have at the moment, but it's something we need to take back to make sure that we are doing that. I'll take that back to Justin and the team who've been doing this and make sure that we are collecting that data. It is really, really difficult to get hold of in a consistent manner. So sometimes you have to deal with softer data than we like in the NHS. But yeah, so I think that's a great point.
And I'm aware that it's early days for you as yet, but I just wanted to be clear we got a strategy to actually obtain the data. But if you could
I don't think we
make
have
some inquiries, that would be great. Thank you. Yeah. Jane.
Just take up the point that Councillor Curley brought up about diet. I think we could seriously underplay it. I mean, if we're talking about prevention, diet has to be a key part of that. There's a lot of research now. For decades and decades, we've had this low fat foods being, you know, a plethora of these things in supermarkets. But a lot of the research coming out now is showing that actually what we should be eating, fat isn't necessarily the problem. And when you take fat out of foods and you replace them with things which are actually toxic to the body. And so I think we've got a nation of overweight people. It's not just about diet, obviously, we've got to do exercise as well. But I think diet has to be really important to this, because if we want to be serious about prevention, we've got to start explaining to people how to eat healthily. I mean, I know we're doing that, but I do think that the food industry is feeding us a lie.
Thank you, Councillor. I tend to agree with that. The Health and Wellbeing Board in Birmingham, I know, has been doing some work on the food strategy, so I was able to see that. And the City Council are doing a range of work on that, and that's how we need to work in partnership, isn't it? Because that's a key determinant of some of the illnesses that we see, as you say.
One more quick question, Councillor Pritchard.
A very quick process follow. I take your point about the chairmanship of the chairship of the place board. So my comment would be, I still think it's worth having elected representatives on that, and also on the locality and neighbourhood equivalents when they're in. So, like in terms of us being able to represent our residents' views on those locality equivalents of those when they're set up. So again, in terms of that devolution and bringing that resident, patient perspective. The other thing I'd say is clearly, Councillor Curley's, raised some points in the report, and we all mentioned things that possibly could have been changed if we'd seen it earlier. So this is my plea. When obviously a lot of these strategies to this committee is, particularly as you've mentioned, there's going to be a review. Could we have sight of it early enough in a draft enough stage for us to be able to meaningfully change it? And obviously, today can be part of that in terms of the review next year. But it would be, if there is going to be a review, can we kind of see a draft of those reviews before they're kind of signed off and agreed, and so therefore we can have a kind of meaningful input that ahead of time.
Mr. Pritchard, I think you're spot on there. Look, the timetable for this got brought forward not by me, but by the Department of Health and Social Care. So we had to do it within the timescale that we got, which meant that we didn't engage probably as widely as, we did engage widely, but we could have done more. And I think my team have already been talking to the team here at Birmingham City Council, see how we can do that in the OSC over the next year.
What's it?
Thank you, members, and thank you, David, for the presentation. And I think we'll arrange through Fiona and Addy for your team to report back in the new municipal year. But thank you very much. It's been very informative. Okay, the next item we got is the immunisation report update, and I think we've got Andrew Dalton and Leon Mallet, who are here physically, and Kate Woollett is actually here joining us through Teams. So I think, Andrew, you're going to sort of give the overview, and then the rest of your colleagues will join in.
myself who started off, Chris Baggett.
Oh, right, I haven't got your name, Dennis. Sorry about that. Apologies.
Thanks, Chair.
Okay.
So I'm Chris Baggett. I'm one of the service leads in the public health team. And I work with other colleagues who are in front of the committee today on local immunisation system. So you had a paper in February around the strategic challenges facing immunisations in the city. And today's agenda item is a follow-up to that. You have a brief paper from our public health team, which addresses some of the key questions that were posed to us in February committee meeting, and particularly around what the role of public health is within the local immunisation system. So I'll just lay those out, and then I'll pass on to my colleagues from the ICB to talk about the immunisation data in a bit more detail. So in the public health team, and specifically with Dr. Justin Varney as the Director of Public Health, we have a number of roles. The first one is around assurance of the local immunisation system and the activity associated with that and the immunisation uptake. To assist us with that, we have a health protection forum, which is a sub-forum of the Health and Wellbeing Board. That meets monthly, and we receive data and updates and plans at that forum around activity planned to address inequality in uptake and low uptake. Secondly, we have a role in challenging and being a critical friend to plans within the local system. So that's looking at what we're presented with, asking some of those challenging questions and assisting with ensuring we're moving in the right direction in increasing uptake and reducing inequality. And thirdly, we have a role as part of the local system in supporting immunisation uptake and activity around that. And so we are involved in a number of the local immunisation programme groups to specifically look at COVID and flu vaccination uptake and childhood and adolescent uptake and the inequalities associated with them. And like I say, all of this comes together through the Health Protection Forum and through the local immunisation program. There is a diagram in your paper, which we have taken from a Royal Society of Public Health publication from last year. We actually worked, the Birmingham team worked with the Royal Society of Public Health on the paper that diagram comes from, that sketches out the roles and responsibilities within the system. It may look like it's one in the paper. I hope you can see it. If you do want a separate copy or version of that, do let us know, and I can share that with Fiona for circulation. So as you'll see, public health sits outside of the commissioning and the provider relationship. So our role is specifically around assurance, critical friend, challenge and support the local system. So I'll hand over to Kate, who's joining us on Teams from the local immunisation programme.
Morning, everybody. Really apologies for not being with you in person. This isn't my preferred medium. Really interesting conversation today overall about all of the things that have been the preamble to this. As Chris says, we came on the 22nd of February with a summary report, and my task was to go away to present and clarify some of the other things that you were interested in. So we've tried to group these into giving you a perspective and some context on what are those challenges, be really clear about the roles and responsibilities that we've got as a system, and who's responsible for what. Give you a bit of a flavour of the governance arrangements to try and assure you about what that looks like, and to tell you a little bit about the resources and funding. You'll be very interested in access to data and intelligence, so I want us to spend a bit more time on that. And we'll give you a snapshot of our performance across our all age programme. And I think it's important to say that I do see this as an all age life course programme, from birth to older age. And it's one of the most important things we can do to protect our residents, our communities, and prevent avoidable illnesses, but also impact on the wider determinants of health, which you've spoke about really eloquently this morning. So before we get into the detail of that, what I'd like to do is just invite Andrew Dalton to share with you a bit about NHSE's responsibilities so that you've got the context for the fit, and then I'll walk you through a précis of the papers that we've submitted for you.
Thank you, Kate. I'm Andrew Dalton. I'm a screening and immunisation lead in NHS England. So the pack that Kate and I have shared, I've roughly talked to the first slide, but quite not everything on here. So just to be clear, at the minute, NHS England commission the vaccination programmes, the national vaccination programmes, the programmes that cover the life course, from obviously your childhood aims to your pneumococcal and shingles later in life, and then obviously high profile mental flu and COVID programmes. All of the commission of services, there's very much an ambition for, as has been highlighted earlier, in terms of the commission functionation of going to ICBs. There is an intention to delegate the vaccination commissioning. Timeline is not firm on that yet, but very likely to be 24-25 financial year. So for this year, we're working much more closely with our ICB colleagues, although on paper we have the kind of strict commissioning responsibilities, and work much more closely. But I think the answers are by working closer to your residents and citizens, and having our commission a little bit closer to their front doors and spend their time. So that's the big thing in the vaccination world this year and through to next year. That being said, we still are paper commissioners, so we have a governance structure in the NHS England region around this, where issues obviously escalated and brought to. I think in terms of solutions, I think we're very much looking to systems support for solutions at the minute, but that's really the direction of travel. And I don't think unilateral kind of regional solutions are a way forward in this area. Whether that's in terms of performance issues, policy issues, something going wrong, or whether it is the uptake health improvement side. Probably the last thing, so on that then, the ICB then has a structure already around immunisation. The BCPO system is certainly the forefront of the one that I cover in the West Midlands in terms of having an architecture around immunisation already. And the fact that you've got a case in the Young Post is really going down to how this systematisation immunisations. So there really goes into it with an ICB board around immunisations and some boards addressing the programmes for the childhood and COVID. Probably just touch on a few of the providers just to get a feel of who exactly does all of this work. Obviously, multiple vaccinations today. The big workhorse for many of the programmes is general practice. So they do the multi-5 programmes, involving the COVID programmes, and then your persist your pneumococcal for the shingles, pneumococcal for the older adults. You've got pharmacies. So sorry, just to go back on that, that's very much in terms of processing, slightly not the most interesting side in my opinion, much more to do with health improvement. But just for completeness, that's all bound up within the primary care contract. So primary care has a single contract every year. That's the funding for all of that work is within that. There's no funding on top for that. Pharmacies obviously involved in the COVID program, so they can apply to be contract holders and with us, but very much through occasionally, obviously, we have some specific acute provision, so some smallest maternity within the maternity population. That's very much the acute services that provide maternity care. We've got some specific outpatient groups in the flu programme, so some of the regional outpatients, again, acute providers can contract to do that. And for the last thing I'd say, the other really big player is the community trust, BCHC in Birmingham case. So they do the school-aged immunisation programmes, that adolescent program in the big chunk. So those are directly contracted and commissioned by us at present. I think that hopefully gives some idea of the provider commissioner, and then back to the unit case.
Thanks, Andrew. So that gives you some idea of the sort of the complexity of the landscape and the provision. I think what I would say about this programme is it truly does work as a collaborative programme across the whole system with all partners. So to assure you, we are heavily involved with our public health colleagues, our local authority engagement colleagues, across the piece with CVS organisations, with yourselves as well as really good advocates for the programme. So my experience is that this programme is, you know, it can involve everybody. If I can just give you a snapshot of the governance. So we have a senior responsible officer for the ICB, which is Matt Bozeman. He's the interim chief exec for Birmingham Women's Children's Hospital. And we meet as an all partner board, rotating the children's and the adults agenda on a monthly basis for detailed discussions. We've also got really close links, as Chris has outlined, into the health protection boards for Birmingham and Solihull, and close links with Justin and Ruth as advocates for the programme. We've got a clinical quality and assurance group, which is chaired by our ICB Chief Medical Officer from a safety and an effectiveness point of view. And obviously we have oversight from Andrew and regional colleagues for other parts of the programme on a regular basis, monthly with Andrew and colleagues, and fortnightly with NHS over COVID and flu. So that gives you a flavour of how we interact on a formal basis. Just in terms of resources and funding, Andrew has outlined that obviously for COVID and flu, we're trying to move to a business as usual approach. And this is our last Spring Booster campaign that we embarked upon, opening on the 3rd of April for care homes, and actually yesterday for the over 75s, immunosuppressed and housebound. And what's anticipated is we move into an annual flu and COVID booster programme, which is truly embedded within our offer. And that's meant that obviously we've had a significant reduction in funding. We've probably reduced our COVID funding by at least 60%, and we've accommodated those changes. We've shifted our model to be one of much more accessible locally for convenience. So we've increased the numbers of pharmacies that offer a range of vaccines and positive advice, and clearly a lot of the work still goes through our PCN groupings through general practice. As Andrew says, our childhood adolescent IMSA is contract funded. There is no flexible funding over and above that. So when we work with colleagues on this agenda, it is as part of that remit. So we haven't got flexible funding above those terms and conditions. But the development work we're doing on that is really important, and everyone is very committed to improving our position. In terms of data and intelligence, I'm going to ask Leon to walk you through with Andrew some of the local and most recent metrics that are in your performance pack. What I would say is for COVID and flu, we've got real-time information, which has provided a really good, accessible, responsive ability for us to change our plans based on what's happening on that uptake. And it provides us with a detailed level of information on a range of indicators that can tell us how we can best target our efforts across our populations. And for pharmacists, again, they use a system which is called Pharma Outcomes, and it's really important that the information gets into the residents' clinical record, and that happens routinely for COVID and flu. For childhood and adolescent data, the NHSC run a system called CHIS, which is not only produces access for appointments and screening, but new birth notifications, and it's gathered from a range of professionals. Now, that system is being reprocured, and Andrew will be able to tell you more about that. But we are also working with our local digital teams to try and get a patient level extract from our systems to improve that real-time position, because we know that focusing in on specific needs in specific locations is really important, and that will tell us what we need to know about what's happening in more of a real-time position. At the moment, our information is running some months behind where we need it to be, and that means making decisions on targeting becomes increasingly difficult. However, we've run a number of projects, as Chris has alluded to, that are actually about delivery. So I'll ask Leon to share with you the data on the Q project, which is to reduce waits, cleanse waiting lists, and address the requirement for local access to clinic slots. And what that's shown us is that we need to implement that routinely across our system to make sure that everyone is addressing better practices for both coding, booking people in, making sure people have got the right access to those clinic slots at the right time and conveniently. So that's a big piece of work that will make a big difference to access. Want to talk to you a bit about performance and trends, because nationally we can see that there's been a really a steady decline in the uptake of child and adolescent IMS and VACs since 2013. This hasn't just happened overnight, and it's had a further impact on the uptake as a result of the pandemic. But what Leon will point you to is some of the trends in this performance pack that show what we see as improvements in the last 12 months for several of the metrics which are really key to us, one of which is MMR uptake. And at the moment we are looking at that in more detail to see, is it as a result of what we've done on bookings and access? Is it a persistent trend? We don't know yet, but there are some really positive signs of recovery on that to pre-pandemic levels. So this year our focus will shift to 0 to 5s within the 0 to 19 parameters to make sure that our children go to school fully immunised, and that's a really ambitious target. We don't want any child to start school without being fully immunised, because that is their best protection. You may be aware that we've had a couple of schools with outbreaks of hepatitis A, where we've responded reactively to that. We don't want to be responding reactively to cases of measles and have a big measles outbreak across the city. So really important that we all work together and provide advice, information without judgment in appropriate cultural languages, and with sensitivity to make sure that we're addressing the health literacy concerns as well as the uptake. So I'll be working with everybody on that in a delivery group to focus our energies around 0 to 5 uptake. In adults, we saw in the autumn-winter phase a significant change in behaviour around flu and COVID uptake, where we saw a 20% reduction in our anticipated levels of interest in having those vaccinations. And again, a lot of work is underway now to try and find out both why people have had a vaccination and also why they have not. And NHSC are helping us with some of that work across the city. What we do know is that our expected uptake of 68% came in at around 49% for COVID uptake and 42% for flu. So my key concern is that there are still a lot of people across Birmingham who are not at all vaccinated for COVID and or flu. For COVID, we are still offering first and second vaccinations, and we are attempting to get access to around 470,000 people who are not appropriately immunised. So that's the scale of our task. Just in terms of emerging issues, I'm really pleased that the programme's been able to respond proactively to working with particularly our local authority and UHB colleagues, for example, on monkeypox, where we've been able to have a system level offer which has been extremely effective. Hepatitis A I've mentioned. Diphtheria provision for those asylum seekers and migrant groups who are unprotected for that disease, and supported a catch-up programme on BCG for babies who have not been vaccinated from last year. We are keeping a watching brief on avian flu and obviously work with our UXA colleagues to have surveillance on all of that, and both myself and the team are tied into the health protection boards to make sure we've got ongoing discussions about those emerging threats. One of the most important things we do, though, is that we are there to improve equity. We've spent an awful lot of time, energy and commitment this year developing partnerships at a really local level. And you've got some examples in your packs of the things that we've been doing. It's a small selection of what we do, and really pleased with the way that citizens have embraced our offer, not particularly just for vaccinations. We've had several situations where our team have been in and dealt with podiatry issues, urgent referrals, diabetes cases, dental issues, because they are more comfortable having those conversations in a community setting than within a practice. And so we are responding to that by trying to scale up our endeavours with colleagues to make sure we've got the right reach for that offer. I think the message from me around this programme is that we are not in this just for this year or next year. We are absolutely in it for the long haul, and we need everybody to support us with the agenda. So our continued promotion of the programme in the right way, in the right language and to the right people is critical going forward. My team through the System Vaccination Operations Centre are routinely sending you as councillors the information on where we are going on our roving offer with the vans and with mobile pop-up offers, so that you're aware of where we're going to be. And we've got at least 40 locations for that across this spring programme, which does actually end on the 30th of June. So if you get emails that are about that, that's why we're looking for you to talk about it, be a good advocate and support that programme. In terms of education, we are seeking to work with colleagues to dispel the myths around cultural beliefs on immunisations and vaccinations, and that is challenging. But we need as many people as possible to help us with that agenda. So we don't really do MEC in IMS and VAX. We do something which is much more detailed than just a 5-minute conversation, and we're prepared to spend time with people, helping them to understand why these things are important and listening to their concerns and their fears, because this is what drives the decision. So we are targeting vulnerable communities. We've spent a lot of time in 10 high priority wards that have been agreed with Chris and his team, with Justin, to make sure that's where we're having the impact. And what we're seeing is that, you know, some of that work is having an impact on our low uptake communities, which Leon will talk to you about in a moment. But we just want to help our population to be as well as they can be. So I'm going to ask Leon if he can give you a few highlights from the performance pack, and then we're happy to take any questions.
Thanks, Kate. I'm Leon Mallett, Head of Immunisations and Vaccinations at Birmingham Solihull ICB, where I work with Kate and with David. As Kate says, we work very closely with our colleagues at local authority and NHS England. In the data pack that you've got, there is a selection of data around COVID as well as child adolescent IMS and vax. In terms of the COVID data, that covers up until February 12th, which was the end of the autumn 2022 campaign. What you will pick out from there is in a lot of areas, we are within the sort of top 80% of the challenges that we have. We've still got some way to go. If you look at particular communities around Bangladeshi, Pakistani community, Black African, Black Caribbean community, we've got more work to do to try and reach the gap there. We've also got a real challenge when it comes to immunosuppressed and at-risk residents. So they are labelled as our most vulnerable residents. And we do have some way to go there. We work very closely with our colleagues in secondary care to ensure we're wrapping around services and access to COVID vaccinations for those cohorts, but there is more to be done to try and stimulate there. In terms of areas of deprivation around Birmingham, as Kate mentioned, we've got a programme of pop-up and mobile vaccination unit offers, and we are targeting those into the lower decile areas of the city. For instance, we did have about yesterday to one of our areas and achieved another 80 vaccinations, which is great in the eligible cohorts. So we are really trying to target in our resources based on the data that we have. And I think this comes back to the point that Kate made, which is through COVID, we've been blessed with a richness of data made available to us by NHS England, which is granular. It's near real time within 24 hours, and you know it's frequently updated. For other programmes, we just don't have the same granularity, frequency, or availability. So if we take, for instance, the childhood IMS programmes. Typically, there is a lag of 4 to 6 months on the data being available, and it's only on a quarterly frequency. So it's really hard for us to sort of map in any kind of sense of real time what is available. Moving on from COVID, we'll just mention, sorry, before we do move on from COVID, we have seen some real challenges also around uptake amongst social care staff and healthcare staff. And I think there is strong support that we benefit from council colleagues in terms of supporting or promoting uptake, particularly amongst those groups. If we think about those who are caring for the most vulnerable, we want to keep them as protected as possible, but also extend that protection out insofar as possible for those that they care for. Moving on to, before I do move on, we've also seen a shift of behaviour as well over the time. We've gone from the days of mass vaccination centres through to a mixed model of hospital hubs, community pharmacies and primary care networks. And we're seeing a bit of a behaviour shift amongst residents of Solihull towards more use of community pharmacies, therefore alleviating some of the pressure that's there on primary care networks and their member general practices, which, as you can imagine, given all the challenges we're facing right now, we want to alleviate as much pressure as possible. So going into the point Kate made about sort of longitudinal shifts that we've seen in 3 areas of child vaccination. This is a 6-in-1 vaccine up to 1 year of age, the first MMR jab and the second MMR jab. There is a national trend downwards and a regional trend downwards over the 10 years from 2013 through to 2023. And we also saw a corresponding trend downward with some peaks in Solihull. What we have seen, though, is in the last year, a sharper uptake where there is an uptick where there's an improvement nationally or regionally, or an uptick where there isn't an improvement. So our gains have been stronger essentially in the last year or so. In that time, we've undertaken a number of work streams, which Kate's alluded to, around addressing queues. So this is a number of children who can't be slotted into, booked into a slot to get a vaccination because there aren't enough slots available from the practice. They're the ones who decide how many slots to release to the CHIS service that Kate mentioned, but also data cleansing as well. So encouraging them to do some good housekeeping around their data as well. At this stage, it's too early to tell which of those measures is impacted, but from the data, what you can see is if we took our 10 biggest queues in 2021 through to January this year, we reduced the queues overall by almost 1,000 slots from a queue of 1,900. We are working with practices both individually and collectively through quality improvement forums to really share good practice and good approaches to really try and improve the offer. And that offer needs to be about good access for their parents and children, but also making sure they've got sufficient capacity and also that they've addressed their data quality needs. We've also seen, I suppose, to pull out from that, that some practices haven't necessarily engaged in the same way and therefore haven't been able to address their queues in as strong a way as possible. And it is, I think, trying to recognise what those individual factors are where those changes haven't been able to take place. And that brings me to the end of the data section.
Thank you very much for that presentation. That was really beneficial, I think. Members' questions. Councillor Tilsley.
Thank you. I read the report. I thought the startling statistics were on page 115. That is healthcare staff uptake on COVID and flu. Now, in the presentation, colleagues have been keen to promote dispelling the myths surrounding immunisation. If we can't dispel the myths to healthcare professionals, I think we're on a pretty awkward wicket, aren't we? Because these are the people, and if you look at the statistics, these are the frontline staff who are actually, with COVID, seeing the results of not being immunised for COVID. And as some colleagues around the table know, I did a weekly news email to my database, which included the number of deaths that there have been within Birmingham. Now, nurses, doctors, PAMs are seeing the effect. And if that doesn't dispel the myths, what does? So I think that there's an enormous marketing campaign that needs with our own NHS staff, because COVID will be one of a number of pandemics, no doubt about it, apart from the annual flu infections. Now, what I would ask, the question is really, are these statistics comparable with other NHS regions, NHS trusts, or is this something peculiar to Birmingham? Because it does concern me, because if I go along, I know my daughter was taken into UHB at the height of the pandemic, scared stiff. And according to these statistics, she had every right to be scared stiff. If she could go to what should be a place of safety and be infected in what should be a place of safety. So I am very concerned about the fact that the NHS has not got across to its own staff to dispel the myths.
Is it okay if I come in there, Kate?
Pregnant silence.
Yes, can I just respond to that first? I think we all share that concern Councillor Tilsley, I think there's been a massive behavioural shift. Some of the feedback that we get is, it won't affect me. I'm already vaccinated. Why do I need another one? I'm fit and healthy. I'm not going to get ill. I haven't got the time. I think this autumn winter we have gone as a programme out of our way to in-reach and outreach to those staff. So across all of our NHS trusts, we've offered an in-reach facility during the day, going to the wards, providing an offer which is accessible, having those difficult conversations, and also offering that at night. Now, that has increased our uptake, but not significantly enough. I think we need a better way of understanding the uptake as well for frontline staff per se, who will be at risk. COVID is still with us, it hasn't gone away, it's still mutating. I think this is why for the winter we are dedicating our time to developing marketing and strategy developments that tactically get to those people who are resisting that offer. Now, one of the things that put people off having the vaccine 2 years ago was that they were told they had to have the jab or they would be made redundant. That's had a massive impact on people's response to taking a vaccination. They're almost saying, I'm not going to be told that I have to have a vaccination. So there's a major uphill struggle around that. We have, as I said, done everything we can possible this autumn winter. What I'm concerned about is frontline staff who we don't count, and also within primary care we don't actually count that as well as we could. So I think you make a really valid point. We need all the help we can on that.
Thank you. Thank you.
Jones?
Yeah, first thing I'd like to say is in terms of accessibility, I'm glad that you've seen that pharmacists are an untapped resource within the NHS, because I lived in France for 2 years and they have a far bigger role over there. And so, you know, it's something I used to rant. I used to work for an MP. It's something I used to rant and rave to him about, you know, and I'm glad to see that finally the NHS is actually using them appropriately, because they are very skilled. In terms of the COVID vaccines, I think, yes, it is a concern that NHS staff aren't getting themselves immunised, but among people I talk to, the reasons you gave are very different to some of the reasons they give, and one of them is people are concerned about the vaccine itself. You're going to have to get round that, because whether you like it or not, statistics have shown that more and more people you can't. I mean, it would appear there is some link now with certain sort of reactions to the vaccine and death. And I think you've got to address that. If you don't address that, I think you're going to find that more and more people are just going to not take it. So how do you think you're going to get over that one? Because there just seems to be an increasing feeling among the public that the vaccines are actually as much a danger as COVID to them. That's what I've been picking up.
Yeah, so Chair, if it's okay, I'll respond to that. So I think there's several things going on there. I think there are benefits and burdens of social media, and information travels really quickly. What I would say is there's a huge amount of misinformation out on those channels that we come across every day. The second thing to say, and we're not going to stop that, but what we do need to do is produce information which is accurate, it's reliable, and it gives the facts, and that's what's most important. Secondly, having conversations with people who have got those fears to try and understand where that emanates from. And I totally accept we're not going to turn every body into a vaccine fan. We won't be able to vaccinate everybody, but what we would be able to do with a really stellar approach is to reduce the level of risk in our population with those 470,000 people. If we even got 50% of those, that would have a huge impact on our position. So I totally accept it's a choice. We can't force people to have a vaccination, but what we can do is give them the best information that's available, and take time out to have really good conversations about what it is that they believe and what it is they're fearful of. And if then they choose not to have the vaccine, then we've done our best. I think that's all I can say.
Thank you, Councillor Pritchard.
Thank you, Chair, and thank you all for the presentation. Reading through some of the case studies that you provided about some of the kind of working communities and in hubs, and around those conversations that we've just heard about, obviously that sounded really positive, and it sounded like, you know, at least there was a chipping away at maybe some of the fears and the misinformation and the problems with that approach and that conversation approach. It does, two things struck me about those examples though, and I completely accept that they are case studies just to highlight some of the approach, and it doesn't show the totality of it. But it was that it's obviously quite resource intensive to kind of do that, and I think it's the right thing to do, but it is very resource intensive to do that. And the other thing is that one conversation or one visit doesn't get somebody jabbed. And that was quite clear from a lot of those case studies that one visit, they might have had a good conversation, but it didn't result in most of those cases. You look at the statistics that were provided as part of those case studies, it did not result in them having a jab, even though it was there for them and they'd had a good conversation, which had at least moved them along the spectrum a little bit and built some trust. It didn't actually result in sealing the deal, as it were, getting them actually jabbed. And that to me said that it's an ongoing thing. It's repetition. It's an ongoing conversation that needs to be had, which obviously then makes it even more resource intensive. And so my question is really, how do you ensure that ongoing repetition with those sorts of intense conversations happens if you're only having a hub visit a particular neighbourhood once a year, for example, or you know, that only happens once in a blue moon as a kind of nice thing to do. Well, we've done that this month. We've been there. We had some nice conversations. Nobody got jabbed. Without that repetition and that follow up, it seems the value in terms of the end goal is diminished without the follow up. And so, how do you ensure that happens? That it's not just a one off, but it's part of a program.
Yeah, so that's exactly the point. We embarked upon this approach to test out what would work, and it's fair to say that we've explored a number of approaches with a lot of different organisations, and you're right, they are a snapshot. Repetition is the way to go, but what we want to do is make sure we can scale this up across all professional groups. The vaccination and immunisations team is not going to do this on its own. It needs everybody to adopt a standard, intelligent approach to how you have those conversations, which are difficult. So that's our aim this year, is to make sure that we scale up our offer. So first thing to say is we are repeating visits to those locations so people know when we go. Ladywood, Perry Bar, Nechells are three really good examples of where we've been back and we've had repeat success. For everyone who doesn't take up a vaccine, we've also got examples where a lady has come in, asked the questions, fearful, sceptical. We had a turnaround situation with her. She had a vaccination, she left the building, and half an hour later she brought back her husband to have his. So I think it can work both ways. But I completely take your point. I need everybody's help to give a consistent message and put this back on their agenda to support us to protect the population, because without that we're not going to get there. And I think, you know, professionals have got a really good place and should be doing this routinely as part of what they say to people on a day-to-day basis across all ages. I think the CVS organisations we've worked with have been incredibly helpful, and it needs to stay on their agenda, and we need to support them with that, because it's difficult for them to sometimes buy into that and be able to maintain that. So we need to support that locally. And then I think also, as a good public citizen, we need to speak to our friends, our neighbours, and continue to keep this on the agenda. Because if we don't do the best for our newborns to 19, this is never going to get embedded into the way that we protect ourselves. And we've all been talking today about avoidable illnesses, and these are absolutely avoidable if we are immunised and vaccinated. So all your points are really well made. We're using the Blacher project to support some of that into vulnerable communities. What I didn't say is that our focus in autumn winter was also with those who are homeless, serious mental illness, learning disability and autism, those who suffer from addiction, and those people are all on our radar on an ongoing basis, cycling through the city to make sure we pick up those people who have not had initial vaccinations for COVID, flu and anything else. So catch-up campaigns are really, really important, and that's our mission, to get everybody involved in this agenda on an ongoing basis, not just for 12 months. It's got to be, you know, forever.
I think there's for me this kind of bespoke approach. The business is just about sort of immunisation of that service and everything else. That's going to be hard to fund going forward for the numbers of people that we need to fund it on. I think for me, it's about bringing that into other services, and some of those services are things that this organisation commissions as well. So whether it's the education and the social care, looking to do things different, have those conversations in different places where it becomes more so everyone has to do. I think that's something that probably needs to explore going forward.
Okay, thank you for that. Councillor Hart, you've got a question.
Yes, I've circulated the information about the COVID vaccination service for Ladywood Ward. I notice, of course, it's out on Victoria Square. It's here by the town hall. It's in Ladywood, but it's not exactly the centre of non-COVID take-up for the ward. It's not necessarily very accessible for those communities. So, I mean, I've got one or two other points to make before I do what I ask what you think I'm going to ask. I started to think it through. Wouldn't it be better on Central Ladywood outside the shops, or down on St Mark's on King Edward's Road by the shops, close to primary schools, to engage with children and their families, to get their elders to come in and more vulnerable people to come in, or the various cultural groups to take it up. But is there evidence that people in those groups, reluctant groups or vulnerable groups, that they don't want to be seen going in, having their vaccination? Do you have evidence of that? Is that why ours is outside this building on those dates, which I have, as I say, I have advertised. Another question is, on my list, our list, we circulate all the known voluntary groups and community services, all the various ever-growing groups of connectors, navigators, networkers, signposters that seem to be shooting up all over the place in this city, I think. So it's their way. But are you going directly to those groups on your mailing list with this information for where you can get the vaccinations? So, I mean, finally, well, apart from that, I think you're better off being on the number 8 route. You know, for Ladywood constituency, that city centre ring within the constituency as well as just the ward. Would you be able to give me figures for the uptake at the facility outside here, those several dates, for people who require, you know, I may even pop in myself because I've been one of these people obliged to lock down and so on. Could you give me figures for the update, and if possible, postcodes? I don't want to know names or house numbers, anything like that. So you just get a handle on just how pertinent this is to people who live in Ladywood Ward and the surrounding wards for that matter.
Right, can I, respond if that's okay, Chair? Regarding Ladywood, it's not just the Victoria Square site, so we have some satellite sites from practices that are also in Ladywood, plus we have Dudley Road, Laydite Pharmacy as well, so there are other
Tell me
sites.
about them as well.
In terms of linking postcodes of patients or residents who may have been vaccinated to where they've been vaccinated, we've got no way of having or access to that data. What we can share is uptake data on either a lower super output area or a ward or whatever, so it can be aggregated up. So we can look at that, but I can't tell you where they got vaccinated, unfortunately. All I can tell you is what the rate of vaccination is. And I think the other thing that just need to bear in mind is mobile vaccination sites. And we continue to, we've put allowance in to increase our offer, so we can always look at more sites. What we've got to bear in mind is there needs to be certain infrastructure that's in place to be able to make that happen. And that means a sort of certain degree of flat surface to work from to position a van. We need access to certain utilities, etc. So you know, absolutely, we can pick up that conversation, you know, outside of the meeting. But you know, we do have more resource beyond Victoria Square. And then in terms of understanding people's attitudes to why they haven't come forwards, I think that one's really hard to sort of test, unfortunately, unless you survey. However, we are working with an organisation called NAFT, which will be looking at a particular sort of segment of the community, and in terms of their attitudes towards vaccination or not having vaccination. That'll be an independent piece of work that we won't oversee, but we will see the results from. So there is kind of a mix of kind of answers there.
Please, Chair.
Quickly.
Numbers of people who use the facility on Victoria Square.
Yeah, so
you know, at the end of the run of days. And secondly, I would like then the information as well as about, you know, the mobile one out here for all these facilities at GP surgeries and so on further afield, so we can signpost people there. Someone may prefer to go to another GP's practice rather than their own, for instance. I don't know. I'm not a refusenik myself, so I wouldn't really know what they do. So I would need just a simple bullet point for you can go to any of these all your own. This is what you can do. I'm not promising people read our email messages on our distribution list, but I like to think that it does make a difference. That's all. Need information.
If I may come back, well, there's a mix of three offers effectively when it comes to accessing a vaccination. A walk-in offer where somebody goes without a booked appointment, and a lot of sites do offer that, but not every site. National booking service, which all our community pharmacies are on. So you know, any resident can look to see where they would like to book on what day.
Refusenik, not any residents. Refusenik isn't going to do that.
I appreciate that, but yeah, we can circulate and share sort of sites. But what I suppose needs to be borne in mind, those sites will be operationally different. So certain days they'll be operational. You know, it's not like you can turn up at any time necessarily. So we just need to be careful, I guess, how we present the message.
Just briefly, I thank you for your presentation and all your efforts. I just wanted to kind of check to see what efforts are being done to make the service culturally sensitive, or and what EDI efforts you're making to communicate with Black and Asian communities predominantly. That I would really hope that you're working very closely, and staff involved are representative of those communities. It needs to be with, not to. And secondly, I just have, I echo the praise of pharmacies of Councillor Jones. They are incredible, but they're in crisis, and they have been for a really long time. Last month, there was announced potential of 1,300 closures of local pharmacies. I just wondered, how is threat of local community pharmacies closure being considered and anticipated, and if there been any amendments to plans and programmes as a result of that?
Yeah, so thank you for your question. I mean, we are blessed to have really, really constructive and positive relationships with both our PCN groupings and pharmacists for this programme. The pharmacists go over and above. If they have specific needs where we can support them with that, we will make sure we offer that. We've got a high number of pharmacies which are within 5 or 10 minutes walk of where you live across both geographies. So accessibility, yes, we are supporting those who are able to deliver in the volumes that we would expect as a minimum level per week, and that's 50 per week. Those who are not able to do that, unfortunately, we can't always support them to remain on the programme, but we do all we can to provide options for incentivising people to use that pharmacy so that they can remain in the programme, and we've got loads of instances of that. Addressing the culturally sensitive issue, absolutely. Working with Chris and Justin and the team, we've honed in on 10 specific wards this year, which is on the council's agenda. We are absolutely at one with those communities and wards to make sure that those are where we emphasise our effort. And we've agreed that, you know, those groups who have particularly low uptake, Bangladeshi, Pakistani, Black African, Black Caribbean, Arabs, we have been focusing on those groups as an example of where we have intensive effort. That's been particularly rewarding over the autumn-winter programme. We're not going to see huge numbers in some of those community settings, but that's not the point. The point is that we're there. We can make sure that people have accurate information, and we're not the ones disseminating a lot of this information. We're working with cultural leaders, community leaders, to empower them to do the same. And they're happy to do it so far, and we've been really pleased with how they've responded to us on that basis. I think the other thing to say is we've had intensive effort with specific street teams where we've gone out and used resources to support that with retailers, you know, people coming into restaurants, shops, local facilities, to make people aware of what the current situation is with COVID and flu, and to encourage them to buy into the opportunity to support those messages. And that was we did something specific in December, and that was really good. So as I say, we're blessed with a really good, strong team of bank staff who live and work in and around the Birmingham area, and we specifically invite those bank staff to work with us to deliver those sorts of programmes, because they can communicate much more effectively with those communities than we can. So and also I see that as a really good way of supporting people into jobs that they might not have had the opportunity to get into had they not had these experiences. So for us, that's a win-win, and we continue to do that throughout the programme for COVID, flu and childhood and adolescent IMS and VACs. So really important that we use local people from their own communities to do that work.
Thank you for that. I got an observation and then a question myself. There's been various comments made regarding factors that may have led to the reduced COVID vaccinations uptake. And I'm just wondering how much you feel the view that people may feel that COVID is a condition that is now in the past. It actually builds into the fact I don't need to take a vaccination because this happened 2 years ago. And then the question is related to the MMR. It's really positive in the last 18 months there's been an improvement for MMR vaccinations for age of 2-year-olds, but we're still way below the target level we should be at. And I'm just wondering, because looking at your graph, we haven't met it since 2013. So I just wanted to know, when did we actually last meet the target in Birmingham and Solihull? And then for the 5-year-olds, we seem to have bucked the trend where nationally and regionally, the decline has slowed down in its intensity, but in Birmingham, there's actually been an improvement. And I just wonder if you got an observation in terms of why those factors have happened. Thank you.
Okay, so in terms of the past, I couldn't answer that question directly, but my colleagues may be able to. But we know that we didn't meet it in 2013. I think the other thing to say is that it's very different across both geographies about where that uptake is. So whilst that's an average position, there will be some of our locations across the city and in Solihull where we exceed it or meet it, and there'll be other places where we absolutely don't. And addressing the issues where there's the lowest uptake is our priority. So, for example, in West Birmingham and East Birmingham, we know we've got to have much more emphasis because of all the health inequalities and associated wider determinants. We would place more emphasis for this programme to increase the uptake in those two locations and hope to sustain the likes of the uptake in others such as Solihull and maintain that position. The question about the MMR vaccine is very valid. We don't absolutely know the reason for the uptick in those three situations, and it needs close monitoring, and that's really why we need local real-time extraction of data, which we're working on to try and drive that conversation much more responsively, because as you know, without factual and really good data turning it into intelligence, it's difficult to act because you're always looking retrospectively. We work hand in glove with our public health colleagues to try and ensure that the focus is always on health and well-being, and it's not just on IMS and vax, because that's a turn-off. So people don't believe that COVID is with us anymore. You're absolutely right. It's in the past. So I think talking about COVID vaccinations all the time is not the way to have the conversation. It's really about how are people coping, what are their real needs, and as part of that protection offer, that is one of the options. But yes, people are very fed up with hearing about COVID vaccinations. So I hope that helps.
That's fine. Thank you, Rich. We've sort of run over time here, so I wanted to thank the guests for the presentation. I think it's been really useful. I want to thank members for the questions you've actually asked. Since I've just mentioned we're over time, what I wanted to do is propose that we extend the meeting by quarter of an hour. I know we've got the council meetings at 1:30, but we've got another presentation, which is going to be a brief one on the staying independent at home. And then we've got to look at the items we're going to be recommending that goes forward the 2023-24 programme. So can I thank you, Andrew, Chris and the team very much, and David as well, and Kate.
Thank you so much for having us.
Thank you. No, it's been really appreciated.
Thank you. Bye-bye.
The last item has been introduced as a sort of an add-on, and this is to look at the staying independent at home adaptation and improvement service strategy. And we've got Tim Zedeb and Michael Walsh from the adult social care team to give a presentation on the update on the recent cabinet decision. We've probably got about no more than 10 minutes. So if you give a very brief presentation,
that's fine.
Ask members questions.
That's fine. No problem at all. We've got a few slides just sort of recognising really that we circulated quite a large amount of information in the pack. So there's quite a lot to digest there. So we just really thought it'd be useful just to have a short presentation just to kind of navigate through that. Really hope that's shown on there. So I suppose context really starting off, we're bringing this to scrutiny now following a delegated cabinet member chief officer decision to go out to procure a new lead provider and subcontractors for the staying independent at home service. Really, this marks a new set of delivery arrangements for this service area, and most importantly, really enables us to fully implement the staying independent at home policy, which was approved by Cabinet back in March 22. So just context, first of all, that the council each year receives grant funding for aids and adaptations to help people live independently at home. That's the Disabled Facilities Grant. What we've done through bringing in a new policy that enables us to exercise greater powers around how we use that grant in a more flexible way, and that's really the purpose really of bringing that policy in. It gives us discretion, gives us flexibility, streamlines the process, makes it easier for citizens to access and for us to support people in that way. So what's the policy for? As I say, it's around enabling people to live independently. The policy we brought in is particularly focused around trying to support people avoid the detrimental impacts of waiting to go home from hospital or intermediate care setting, whilst improvements are needed on their homes, to speed up that process, get them out, get them back home into a better environment for them. And as part of the policy development process, we've done a lot of work around co-production with citizens to really understand what was important for them in the process. And this slide, it's in the pack as well, that's been circulated, it just picks out some of those principles really, or the messages people were telling us in terms of their expectations of how the service operates, what they're wanting to get out of this. As you can see, the facts there around staying independent, around choice, around supporting the whole of the family, whole of the household. Number of points there around quality of communication and information during the process. You're talking about works to people's homes. That's always a potentially stressful and difficult process. So how we manage that in a really quality way is really important. And then involvement in decision making as well. So the policy was approved, as I mentioned, March last year. The elements of that brought in, obviously, we still have a mandatory obligation around disabled facilities grants. That's a statutory requirement. Policy has also enabled us to provide top-ups to the £30,000 maximum grant. Appreciate cost of building works has really increased over the last number of years, and there's often just a sound reason for doing more works to people's properties as well, because that keeps them independent, enhances quality of life. And then those two new areas of discretionary assistance around support and discharge, primarily from hospital, then also works to keep people safe and independent, and to avoid admissions into hospital or into residential care. Again, just being able to more flexibly and more quickly provide that kind of assistance. So what's in scope for this? I'll start with what's not in scope. So not in scope is the equipment loan service, or repair and maintenance of lifts and hoists, or the cleaning and holding support that's commissioned separately. Services that are in scope are minor works, major adaptations, and key saves. And I'll hand over to Timsy there just to talk you through more detail of the actual service and how it operates and how that's going to change in the future.
So just to give a quick overview in terms of what's remaining in-house, so the decision-making process of the assessment side of things, so the formal occupational therapy assessment or the review of a professional assessment that remains in-house to determine whether someone requires the works that have been recommended. The other part that remains in-house is to ensure the works are feasible and that the works that we do know are actually reasonable as well. And there's a lot of criteria within that that stays with us. So the council retains that decision making to ensure that we are appropriately distributing that grant to those that are require it, and there's equity across the board with citizens that come through to us. In terms of services that are so the aims and objectives of the new service. So as Mike's already mentioned, it's looking at things like ensuring the speed of discharge from hospitals and also reducing the number of citizens that will be going into long-term care and making sure that citizens are actually staying in their chosen place rather than having to be forced into anything that they don't want to do. It's also to assist with emergencies to stop any more intensive services having to be brought in and sort of delaying any of that happening. It's really important to ensure that we continue to make sure that citizens have that dignity to have that choice of their environment that they wish to stay in, and also to help tackle some of the causes of ill health associated with poor living conditions as well. So this is what we're expecting all of the policy will allow us to do. So the service values. So what we the service in by the following. So we're looking at the citizens should retain the greatest control over the decision making that happens within their lives, that they're treated with courtesy and respect and dignity, that they should be personally involved with any decision making that takes place that impacts on them, and to also ensure that we obtain their views on the quality of the service that they're receiving as well, and that the diverse needs of citizens will be recognised and supported throughout this process. In terms of the actual service, the service that we're tendering out for is going to be a 7-day service, stipulated within certain time frames as detailed there. It would come down to the individual provider to understand and on looking through, because one thing we've got to just advise, obviously we're in the live tender process at the moment, and so some of the detail I can't go into, because what we would expect is that any bids that come in, that they would look through the requirements and the specification of the service to determine what would be included. So one of the things here is that we have specified that the provider needs to have a physical location that our citizens can actually visit, so they can actually try out different pieces of equipment, look at different options around building work, sort of tile choices and that sort of thing, just to give them that choice and ability to have to look at things and see exactly what's going to be happening within their home. There's also a requirement for the provider to actually ensure they have interpreting services available for citizens that do not speak English. And also what we would be doing is we would want to ensure that the workforce and the subcontractors that are working with our citizens, that they include the different communities that are within the city and reflect the diversity that we have got across Birmingham. And the service will be monitored to measure and to ensure it's achieving these targets and success that we have stipulated within the specification. So ultimately, what the service specifications are, that the works that will be completed will be based on recommendations either by the occupational therapist or another professional, which will enable the citizen to live within their home. It's a design to build service, which is based on the occupational therapy recommendations. Works required under the discretionary assistance. So, for example, things like affordable warmth, safety and security to remain at home, provision of key safes and their installations, and there's a requirement for the service to be flexible and adaptive workforce, so that they can flex to go to wherever the demand is across the city, and that it is a citywide service. So for the actual contract details, the contract term is going to be for 5 years with the possibility of a further 2-year extension, dependent on performance and budget availability. The financial envelope for this contract is 12 million per year, but this isn't a block payment. This is payment on completion of actual works completed. And there is also a minimum expected level of subcontracting to occur with the contract, for a minimum of 10 local subcontractors to be working within this contract. Where we are at currently, so this is just a timeline to show where we're at. So the ICT was issued in March and is due to close in June, and that's our evaluation and mobilisation periods, where we're proposing that the new delivery would commence from the 1st of January 2024. And if there's any questions.
Okay, questions, then let's go to Michelle.
Just on like the decision to procure this and how you're procuring it. Because from what I understand of your presentation and the reports, that this contractor for a lot of the work won't actually be doing the work. They've got subcontractors in that are going to be doing a lot of this work, and particularly as you're also keeping the assessment in house, which I think is absolutely the right thing to do. Then what actually is this contractor effectively going to be doing? Because it almost feels like I'm kind of layman on this, but they're kind of just a middle person between the assessment and the actual physical work, which will often be done by a subcontractor. So I almost think, what's the point? And would it not be more efficient to have that in-house as, you know, part of the service? You do the assessment, and you get, you know, Bob the builder to come and do the work. So I'm kind of not seeing the benefit. It feels like it's creating an extra layer. So I suppose my question is, what's being done to make sure that there is value for money on that, and it isn't just creating effectively an extra layer of bureaucracy between the assessment and the actual physical works?
So in terms of the actual the contract that's out there, the work the provider is, there is an expectation that they have to deliver some of the services and also then have the subcontracting arrangements as well. So it's not passing out everything in that way, like you said, and obviously that is something that we've been very conscious of ensuring that we're not adding any extra layers in and that we're actually making the service more efficient. And we have done an options appraisal to look at all the different options that were available, and this was the option that came out on top.
I mean, some of the rationale behind it is based on I suppose issues with how the service operates at the moment that we've sort of learnt over experience, really. And one of the issues that we have at the moment is managing workforce capacity across a range of providers at the moment. So we're essentially transferring that risk and obligation to the lead provider to do that managing of the workforce capacity. Our expectation is that a suitable provider is there able to do the job. That's their risk to manage that, and we see that as a benefit to ourselves. And as Tim just mentioned, our expectation is the lead provider will be doing around about 50% of the total works themselves as well. Yeah.
Thinking about local suppliers and one that comes around where small local suppliers are viable, there's a risk in these larger arrangements that it differentially disadvantages more local providers. So what reassurance have we got about that?
Absolutely, Councillor. I mean, we've been very clear on that in our delivery model, and that's been important to us in how the model's been designed. Obviously, we are constrained by procurement legislation as to how far you can actually push that. We think we push that as far as we can in terms of an expectation that we have at least 10 local contractors potentially doing up to 50% of the total work. We've worked with our procurement colleagues on that, just to really understand what we can do within the constraints of legislation, because it's important to us clearly to try and keep this working in the local economy, support local businesses. So yes, as far as we can, we've tried to do that.
Just to follow that, I think in the social value and assessment, presumably that criterion will be
absolutely.
We can make explicit that the weighting reflects the local successful tenderers' abilities, needs, and qualities, etc. In relation to that. Therefore, by the way, make sure the cars aren't stacked against them.
That's right. I mean, without sort of going too much into the procurement questions, obviously there's a procurement exercise on the moment, so we have to be a little bit careful. But clearly, in terms of that evaluation, that's an important factor, as is the provider's ability to respond to the diversity of the city as well, and provide that quality of service. But yeah, as I say, kind of yeah.
Questions?
You've already referred to the clean air zone and the implications there, and you're going to be considering it more fully. There's already evidence within the Middleway in the clean air zone that traders from outside are possibly overcharging, but adding elements on for having to bring non-compliant vehicles into the clean air zone to carry out paving work and stuff like that. I should think some of these would be quite the same type of trader as you would be procuring to do the adaptations. And you've also got a green and sustainable element to awarding of contracts. Are you going to be ensuring that everyone who's doing work within the clean air zone actually is using compliant vehicles? And do you sense that this might impact on the cost of the work that you're covering?
Yeah, so in terms of it's a big push for us to make sure that we are going towards that green and sustainable side of things. Again, without going into too much detail from a costing point of view, you know, the costs are going to become very sometimes in the work. So that would be something that would be taken into consideration as part of the ongoing costs for delivery. But again, with the social value, we have ensured that we've looked at that side of things as well. Like I said, it's very difficult to go into it in too much detail because of it being a live tender, and obviously
it won't be a case of, you know, equipment falling off the back of a non-compliant lorry. Will it? It'll be good traders who hopefully very, very much so are driving compliant vehicles into the zone.
And I suppose again, we're going to, but the purpose of that valuation process is to get the people who are best in class in terms of those aspects. Yeah.
Any other questions, members? Can I ask one then? I know one of the issues of the current contract, the last one, was delivery of works in a prescribed target time frame, certainly for major installations and adaptations to properties. And I'm just wondering what's been done in terms of making sure the new contract is going to be monitored sufficiently in terms of making sure that target groups are actually being reached and the overall project is moving forward effectively. Because I know there's going to be a number of subcontractors potentially brought into it. And I know sometimes if you had work done on your own property, bringing subcontractors in can extend the potential timeframes.
As part of the initial contract, we need to have sight of an understanding of who those initial 10 contractors are, the minimum 10 that's stipulated. So as a department, we would have those details to ensure that we can monitor, so it's not just anyone being brought in and out without our knowledge, because we want to ensure that they've got that sustainable workforce at all times. That's really important for monitoring. We've also ensured that in terms of from a resource point of view, that we have got the correct resources in place to make sure that that contract management is very tight, and we really review those KPIs that are within the specification as well. And we have technology being put into place that we can easily report to make sure that we are achieving those targets, and that we can really, you can move away from being that reactive service and being proactive and keeping on top of and making sure that we're not getting these delays and that we're reducing them.
Okay, thank you for that. Okay, I think there's no more questions from the members. So can I thank you for the presentation? Because I know you've done this at short notice, so I want to thank you very much for that. So the next item is the work programme, which Fiona's going to run through with us briefly.
Yeah, I'm very conscious of time. So the agenda item was to reflect on the work programme for this year. But if members are happy, if you've perhaps got any comments that you want to feed back to us when we're thinking about planning for next year, perhaps if you want to email those through rather than go through a full discussion at the meeting, if you're happy with that.
Do that. Big comments.
What I would like to do is just highlight some of the issues that from the current work programme, from other discussions that you may want to put on earth. I think Councillor Boyd can talk about the menu of options that committees may want to develop and work through next year. So actually the first piece of work will be to continue the children and young people's mental health inquiry. The work of the Task and Finish group will continue. And there is a Task and Finish group meeting next week for the members to meet with young people. And members of the Task and Finish group have also been invited to the Education and Children's Social Care Committee on the 17th of May because there are relevant agenda items there. From the meeting today, I think there are issues that you may want to consider in terms of the ICS 10-year strategy and the 5-year forward plan. That there were a couple that I noted, I'm sure Addy would have noted as well. And if members are happy, perhaps for Addy and myself to continue some of the discussions with the ICS colleagues to identify issues that they might want members of the committee to consider next year. The report on immunisations, I think the length of the discussion today showed the importance and interest in that issue. And that was brought to this committee with the view to the committee doing some more in-depth work potentially next year. So we could perhaps again work with members to see if there's some particular aspects of that the HOSC, this committee, would be able to add value and develop. Monitoring any recommendations from previous inquiries. I think that's something that Gail had previously had her, was on top of. So I think Addy and I just need to go back to the previous inquiries to see if there's any recommendations from that. There's a regular reports that you receive on performance management information from adult social care, which you may want to receive again next year. There are items that are included in your pack on the information action tracker and the items to be scheduled in the work programme that again we can keep on the list that you may want to consider. The statutory role that the HOSC has, so if there are any substantial variations or development in service that come through from the NHS, that will be a statutory function that the committee would have. And then the ongoing work of the joint HOSCs for Birmingham and Solihull, the UHB reviews. There's been discussions about further meetings for that. And one of the key issues that came from the joint HOSC meeting last week was around workforce planning.
It was, yeah.
And then the Birmingham and Sandwell joint HOSC around the transition to West Birmingham. That's an ongoing piece of work. So that's perhaps not as short as I'd intended because there's a lot of work that this committee does. But if you're happy for Addy and myself to pull that together into a format that can then be brought to the committee next year, and that'll be sort of a starting point for discussion. No commitments because it'll be for the committee next year to decide what they want to do. But if you're happy for that,
the only other thing I'd say is obviously I've brought up now in a couple of meetings on the trot about reports and decision making being brought to the committee in enough time and that they're done well in advance of it being finished effectively, so it's in a draft form that we can genuinely actually feed into and change and have influence on. And obviously I've made the point that's something from the officer or external organisation side that they should do, but I think it'd be useful if as a committee that we were on top of the forward plans for next year and kind of if we're seeing something coming up in 3 months and 6 months that we've asked, we've timetabled in and we've asked for those to come in draft form 3-6 months earlier, if that makes sense to this committee. And so we're kind of proactively doing that from our end as well as also kicking them to make sure they come earlier. And so we made that request. So if we can build that in and they'll look at that forward plan and kind of, okay, 6 months before that is a reasonable time to have a meeting engagement. Let's schedule that in and get the relevant department or external organisation kind of teed up for that.
I think a lot of those conversations already go on. I think it's just sometimes difficult for the scrutiny officers to actually get the other agencies to actually link into it on a time scale that really works for us as a committee. But I take your point. It's a really valid one, but I think it's work that has been tried during the last 12 months.
Yeah. And I think the other part is that what I've seen over the last year is that the committee has a very full work programme that's almost filled at the beginning of the year. So it reduces the ability to introduce new items during the year. So I know it's something that, discussion's been happening about how to develop a more flexible work programme, so it's not quite so rigid and fixed at the beginning of the year. So we can certainly build that in.
Yeah, I mean, there are some gaps, and I think also, but some of these decisions we will probably know actually from the beginning of the year will be coming up over the course of the year, and obviously the requirement for forward plan decisions to be on several months in advance. So some of it we can anticipate or will know.
You can do. I think if you look at the joint task and Solihull, we've actually added 2 meetings onto that this year. So I think, we've had to respond as flexibly as possible. Okay, so this is the last meeting of this municipal year, so I'd like to thank members for your contributions. I think it's been a really interesting year, and it's been a really challenging, but I think it's been an enjoyable year for people. The date of the next meeting for the new municipal year in 23-24 will be confirmed in due course.
If I could just flag on the agenda on CMIS, the date is actually given. That is an error because it's not been set yet because it hasn't been agreed by City Council. So that's a provisional date at the moment.
Okay. Any call-ins for council action? I assume not. No. Any other urgent business? Authority to chair. Thank you. Thank you all for your time today and over the last 12 months. It's been appreciated. Thank you.
That was really, it was a long meeting.
I've been really wanting to be, I feel like it's annoying that my health. I know, like I can contribute quite well into this committee, but